Dr. Khanna? Can you guys hear me?
I can hear you. Hi.
Hi.
So it was giving me the option to share my screen for some reason.
Giving everybody the option to, everybody logs in. So Melanie, you might, actually, no, we decided that except Russ, no one else was going to share, right? So we're fine.
But yeah, normally if you're...
You guys have all the slides, so you don't need me. Yeah.
Yeah, we don't. So expand to view video. So we've got it on record.
You need to put that in presenter mode, the slideshow mode.
I did.
No, like you...
Yeah, just did. Yeah. Yeah, there.
No.
That's good?
No.
Mm-hmm.
This is what I see.
So you're seeing that?
That's what I'm seeing.
So Melanie, what are you seeing on that?
Sharing your screen.
I see like two slides, one that has the agenda and one that has announcements. It looks like the presenter view.
Oh, yeah. So display settings. Swap presenter view and slideshow. No. This.
There you go.
Oh, so this went there and this came here. Now what are you seeing?
Now I just see the agenda.
Yeah, that's what we have to do. Okay, so you can't see the chat box. We have to see the chat box. Let's see. Where is the chat?
So this is...
Are you seeing the chat box?
So I can see the chat box and look, it says host, send to host and presenter.
Oh, what?
So here, let me check.
So you're going to check it out. So we have a laptop and a computer both. And I need this to get a little smaller.
Actually, make Melanie the presenter so we can make sure that she can see the questions that I sent her. So we can do a test and make sure that.
Make Melanie the presenter.
Where's the list of participants?
Wait. Show hidden icons.
No, I think it's going to be up in here. Go up to the sharing. Yeah.
This side? Make presenter
Melanie.
Okay, Melanie. Melanie, you're the presenter.
Okay, so if I do, let's see, share my screen.
Yeah.
If I do screen 2, can you guys see my slides?
Yeah.
Okay.
Worked beautifully. All right, so now if you could send it back to me.
You want me, so I'm going to stop
I can
sharing.
take it back.
Oh, so, okay. So what happens, we need to put change in the announcement. So what happens is that you can either send it to the host, your questions to the host, or to the presenter. So we need to put in the announcement, send question to presenter.
To the presenter.
To the presenter on the slide.
All right. Okay, now find my share screen. Share my screen.
Somebody keeps trying to call me. Hold on one second, guys. I'm going to put you on hold.
All right. No problem. Can you see how many people registered? I just saw them right now.
So I can't see how many participants.
Oh, here. There they are. John Lease is on the call with us. Hello, John.
Hi, how are you?
Oh, yes, you did. We're doing
I'm listening to you guys.
So, go to announcement.
How are you, John? We haven't talked in so long.
I'm very, very well. Thank you. We have a lot going on down here.
All right. We have to come down there and chat with you one day.
And we'll be here, okay?
All right. So you want me to make this into a... You want me to...
Please submit all questions to the presenter and underline that. There we go. And just make that clear on your announcement. Make it red. Go through that page.
That's the rest of it. And now we can make it into a slideshow, right? Resume slideshow. Oh, that's very smart.
There we go.
So we're going to try and start right on time, John, because you are with us.
Okay, hope it's more than just me.
Yeah, I certainly hope so. We have 135 people registered, so I guess they'll start trickling in.
Great, thank you.
So we will be muting everyone, I think.
Do we have all the presenters besides Dr. Haft on the phone? I think I heard Russ.
I haven't heard Russ yet, and I don't think I see him. So if people come in as
attendees, right?
What? Sorry?
You guys all the attendees?
Yes, it's not giving me a mute all option, so I have to individually mute them.
Oh, yeah, this gentleman. You did see somebody else. We're not losing it. All right, we thought we were losing it. Kathy thought it was a
Well, you are not the dead.
Oh, aye to you.
See you
Friday.
Friday.
Are you coming in at all tomorrow?
Not yet.
Oh,
My own
okay.
outfit.
All right, see you Friday. Then.
All right.
Hello?
Hi.
This is Dr. Davenport. Yes, hi. So we are looking for Russ. Has Russ joined us?
Right in the drawer, under the microwave.
All right, so it's 12 o'clock, and right on the dot, I'm going to go ahead and get started. First thing I'm going to ask is if everyone could please mute their phones This, we have a new web system, and it's not letting us
Yeah, definitely. How's it going?
So please mute yourself so that we can go ahead and start.
No, not really. Yeah, a couple no-shows, but for some reason I was blocked out.
There's a man talking right now. There's a man who's talking. Mute.
Get over here. What's that?
Only us.
Oh, okay. What do you got this afternoon? Are you here? I can just hang over here.
All right, so we're just waiting on Russ Montgomery, who's the second speaker, and then we're going to go ahead and start.
I think I have a regular schedule, I think. Do you already do lunch? Yeah, I got something on the way over.
Hello? Hello?
Yeah?
Okay. The PTN call?
Yes, this is the PTN call.
Thanks. This is Roxanne.
Hello, Russ.
I read it on my computer, so I don't understand why I can't read it here. It's them.
Is there any way to walk everyone through how to mute their line? Yep.
If you could just click on the microphone button, which kind of looks like this, where it says mute me up here. Can you see my cursor? The blue one up here, if you will mute yourself, that would be immensely helpful. All right, I'm going to try and start again. So good morning, everybody, and we are so delighted that you're joining us for our MACRA and Value-Based Care Models webinar. We have a lot of participants, and so we really need everybody to mute themselves using this blue button up here, which says mute me. And if you need to talk, we will have time at the end where you can unmute yourself and you'll be able to talk. So our talk today is divided up into the segments that you see. The schedule's up here. I'll start you off with a short discussion on MACRA in 5 steps. We will be talking about the 2017 guidance to which practices are reporting now. And we're going to try and make this as hands-on as possible. The second talk of today is going to be given by Dr. Russ Montgomery, and that will be on how to use the MIPS calculator. We are basically using a MIPS calculator that has been developed by the Qualis group to show practices how to assess the value of reporting these metrics. And that includes not only your quality metrics, but also the 2 other elements that are needed as part of your reporting this year. The third talk today is going to be by one of our coaches, Dr. Marsha Davenport, who will talk with us about how to select the MIPS metrics to report, where to find them, and if they aren't automatically landing in your basket, how to ask your EHR vendor to extract them for you. These 3 talks are directed primarily to practices, and we certainly hope that practices will find this a good forum to come forward with questions as well. The second half of today's talk is going to be on value-based payment. As you see up here, this talk, the first talk on Maryland value-based payment models, will be given by Melanie Cavalier, who's Chief of Innovative Care Delivery at the MHCC. The second talk today is going to be by Dr. Howard Haft, and that talk is specific to the Maryland primary care model that is being developed in our state, and there will be some updates that will be shared today. With that, I'm going to go ahead and move towards, okay, we're stuck. So if you hang on just a second, I'm going to get my thing back. Okay, we got this back up. Here we go. So we have some announcements before we start. Questions, like I said, would be answered depending on how much time is left. We can go over the time at the end for maybe 5 or 10 minutes, and then after that we will ask you to send us questions via email. During the talks, we have built in some time where questions can be asked, and we ask that you submit all your questions to the presenter in the chat box, and they will be answered in the order that we get them. Yep. There are 2 CME credits available. You should have received a reminder about an hour prior to today's talk, and there's an evaluation form there which you can utilize to share your participation with us, and please ask for the number of credits that you attend. So if you attend an hour, please ask for an hour. If you attend 2 hours, please make sure you indicate that. All your evaluations should be sent to Lauren Gritzer, and Lauren's email is right down here for you, lgritzer@o.Maryland.edu. And down here is a CME statement. I'm going to move forward with my MACRA talk. I'm already over time. So what we did was to start a year-long series of talks which are based on practices need to avoid the penalty. And what we did was to offer them a short series of talks with some hands-on guidance following that. So MACRA, as you know, stands for Medicare Access and CHIP Reauthorization Act. It replaces the old SDR, and what's at stake is basically payments. It's about the payments. And in MACRA, it's essentially based on 2 new reimbursement structures, which is the MIPS, which is the merit-based incentive payment, and the second, which you will hear in the second half of today's talk, is the advanced alternative payment models, which are coming into play very soon. So what is the merit-based incentive payment system, which is MIPS here on? And we're going to discuss that, and we're also going to talk about what eligible professionals are going to be measured on. So they're going to be measured on quality reporting, improvement activities, and advancing care information. Considering what is the weightage, how important is each activity? That's what we mean by weight. So quality is weighted at 60% for 2017, and this will change in 2018 to being 50% in quality, and 10% will shift into cost. But for 2017, quality is 60%, cost is 0, and improvement activities are weighted at 15%. Advancing care information is at 25%. There are a few exclusions which we will not get into during my talk today, but they are available to you through your talk with your coaches. Just a reminder to everyone, please mute yourself, the blue button up here. It should say mute me. Please go ahead and press that so that we can. So in choosing a test for 2017, you can select as a minimum amount of data reporting. Hold on just a second. So the minimum amount of reporting that's needed is 1 quality measure, which includes 6 metrics in here, 1 improvement activity, and 4 or 5 advancing care information measures. When does this MIPS system officially begin? So essentially, in 2017, that was your performance period, and that closed on December the 31st, 2017. Submission deadline is March the 31st, 2018, and feedback then becomes available through CMS. We don't know exactly when, but probably more like the end of summer, I would say you'll start hearing from them. And on January 1, 2019, we will start to see adjustments. Please mute yourselves again. That's a request from us again to you. Please mute yourselves so we can all hear everyone talk? Okay. All right, so MIPS scoring for quality is essentially going to be based on these directions up here, which is selecting 6 of the approximately 300 metrics that are available on the website. Yeah, so it doesn't have to mean. There you go. Okay. That was really great. All right. Can you still hear me?
Share your screen again, probably.
Where is?
Oh, she can
hear me. Okay. Thank you, Renee. So we're going to continue. So in selecting 6 of the approximately 300 metrics that are available on the website, we recommend that if you have mute all has to go. Where's escape?
All right. You need to share your screen.
All right. Sharing screen. And here we are. Let's just share this. We can manage it better. Can they hear me now?
Mm-hmm. You can hear.
Good. Sorry about the technical issues. We have a new system, which is just giving us a tough time. Okay, we were on this page. Selecting, can you all hear me? Renee?
It's very weak. Your sound is very weak. Can you increase the volume? And are your speakers on? Sometimes the echo is because the speakers are on somewhere.
I don't think you want this speaker on. No. Yeah, speakers are on high. Can you all hear now? Is it better? This is the highest it goes. Okay, so we're going to continue. There's 6 approximately metrics out of the 300 that are available that you would select from the CMS website. And we do hope that everyone has had a chance to go to that CMS website. It is pretty easy to put in your specialty and pull out the metrics that are available to you. If you report a metric, you're likely to get at least 3 points. If you do well, you can get up to 10 points per metric. And if you don't submit any of these performance data, you will get a 0. So it's better to report than to not report, even if there are metrics that you're not doing well in. There are some bonus points, again, that are available in this process as well. Moving on to advancing care information, there's been a lot of questions that we've been asked around this. Much of this is dependent on the type of EHR that you have. Your EHR will determine whether you have some of the characteristics that are reportable. The basic ones that you want to report on are, the first one is a security risk analysis, which is generally something that you would use a vendor for your, that is recommended through your EHR for this. There are also other people in the community that are offering security risk analyses. If for any reason you can't do that, if you have a patient portal, that's going to allow you to meet the needs for patient electronic access right here. If you're electronically prescribing to the pharmacy, you're probably meeting this one. if you are connected to the Health Information Exchange, which is CRISP, and sending a summary of care, then you are eligible for this particular metric. If you are requesting or accepting summaries of care, then that one applies. We have had a couple of questions in this area from the community around how does a specialty practice share information with primary care if they don't have a secure email system. And I would tell you that one of the ways that a specialty practice can share information with primary care is through uploading care plans to the CRISP. That's one way, and if you're unable to do that and the practice doesn't have a secure email or a secure way of receiving data, then utilizing old methodologies such as fax to make you eligible for some of these metrics. But what they're really looking for in advancing care information is your ability to share data electronically. So I think if you are unable to do these things, please do continue to use the fax until you find your EHR capable of doing some of these things. The CRISP is going around trying to have increased connectivity. And if you haven't connected with your CRISP representative, for all GPTN practices, they can reach out to their coach and we will connect you. For all other practices, please send us an email and we'll figure out a system by which we can help you do that. For improvement activities, participating in the Practice Transformation Network does qualify you. If you look at the domain areas under which reporting is to be done, if you are a patient-centered medical home or participating in the Practice Transformation Network, you are already doing expanded practice access by looking at open slots. You're probably also doing population management because you're looking at your metrics across your practice and taking action on those. Care coordination is already being done in patient-centered medical homes, as is beneficiary engagement. So in the Practice Transformation Network, we refer to beneficiary engagement as patient and family engagement. And so you may be calling it by different terms, but really what you're getting at is beneficiary engagement. Some practices in our network are also doing integrated behavior and mental health delivery, so you probably meet that as well. Most practices simply need to have two categories that they report under. If you have a larger practice that's 15 or greater, then you may have additional needs. But for smaller practices, you just need two of those activities reported for a minimum of 90 days. Okay, so I'm going to invite Russ now to present. Russ, are you registered under your own name?
You need to unmute him.
Okay, we're looking for Russ Montgomery, our second speaker. Here he is. Russ, can you hear me?
Yes.
Oh, wonderful. All righty. Let me assign the screen to you. Russ. Okay. Yeah.
Okay, Okay, can you see my screen?
Yes.
All right. Good afternoon, everyone. My name is Russ Montgomery. I'm a project director at Discern Health, which is a consulting firm in Baltimore focused on healthcare quality, value-based payments, and data analytics. I'm serving as the Quality Improvement Advisor for the Maryland PTN. And today I'm going to be sharing with you a demo of a MIPS calculator that you can use in your practices to get a better sense of where you stand with the metrics in MIPS and what your potential payment adjustment may be given what you're planning to report for 2017. As Dr. Khanna mentioned, this calculator was developed by Qualis Health, which is a Medicare QIO. It's publicly available and it's free. There's a link here on this slide that you can use to find the calculator. It's a long address, so you may just want to Google Qualis MIPS calculator and you can find it that way. It's an Excel sheet, and it's fairly easy to use, as you'll see here as I walk through it. There are a lot of MIPS calculators out there that you can choose from that are publicly available. I chose this calculator because it struck a good balance of being easy to use, but also giving you, I think, a really good, reliable sense of what type of adjustment you may have under MIPS. It's comprehensive, but it's also user-friendly, so I think can provide you with a really good idea of your potential payment adjustment under MIPS. So when you open the calculator, you'll see this cover sheet. One caveat here that's noted that I should probably note as well is that this is really for discussion and strategic planning. It's not necessarily going to predict with 100% accuracy what your payment adjustment may be, but it will give you, I think, a good sense of what you can expect. On this second tab here, there's a user guide which provides you with color coding of all of the different components of the calculator. The most important thing to notice here is that cells that are orange are where you input various numbers. And so everything else really starts to calculate itself. There are some checkboxes and drop-downs, as you'll see, but in general, the orange buttons are the ones that will be most important for you to pay attention to. So this, as you see here, I've been clicking along these tabs on the bottom. You can progress through the calculator. Once you complete one sheet, click on the next sheet, and so forth. And we'll move through each of the categories that Dr. Khanna showed on these slides. So quality, advancing care information, improvement activities, and then cost. And then that will give us an exit report and show us what the potential payment adjustment may be.
Yeah.
So on this slide, really the key pieces of information you want to input here are the numbers of MIPS-eligible clinicians in your practice. So for simplicity's sake, I'm going to assume that this is a solo practitioner, so one MIPS-eligible clinician. And again, for simplicity, I'm going to enter here that this solo practitioner has $100,000 annually in Medicare charges. That will be easy for us. If everyone could please put your phones on mute, getting a little bit of background noise. And for total case volume, I'm going to say here 500 Medicare patients. So you'll need to be pretty accurate when you put these pieces of information into the calculator because it does have a major impact on the results that you'll be getting. That's really it for what you need to enter on this slide. This is really a roll-up slide. The key pieces of information are on these individual tabs. And hold on one second here. Okay. On this slide, or this sheet, I'm sorry, this is where you enter the quality measures that you're planning to report and your performance rate.
Are you okay while you're going home?
Please put your phones on mute. So I'm going to just select some random measures here. Again, you'll want to choose measures that you have the data to report through EHR or through another mechanism. It's really up to you what you choose to report. So you choose the measure ID, and there is a reference table here on the last tab for all of the measures that are part of the quality category. And so you can see this as a reference. So you select the number, it will populate the measure name here, and then you can select the submission method. So I'm going to select EHR, and for this particular measure, I'll put a performance rate here. And you'll see estimated points. This is based on thresholds that CMS has set for all of the measures. Those thresholds are shown here under Quality Benchmarks, one of these tabs. But it'll do all of this calculation for you once you enter the performance rate. So I'll just continue selecting some of these measures so we can see the results. And again, these are totally up to you which measures you choose to report. You can choose measures that you've been tracking internally. If you're a member of the PTN, you're already looking at diabetes, LDL control, you're looking at hypertension and other measures, so those would be likely measures that you would want to report. And again, the requirement here is to report 6 quality measures. And you need to select the submission method for each one. All right, now you'll see here that some measures are not eligible for certain types of reporting, so I'm going to just switch all of these over. It assumes that you're going to be consistent in how you report these, so either through an EHR or a registry or QCDR. So, okay, I've reported my quality measures, and then we move to advancing care information. And here, you do have to enter numerators and denominators for numbers of patients. I'm going to enter in some basic numbers here just to keep it straightforward. 90 patients out of 100 for each of these. And again, you do have a choice of which of these you report. These are, there are some required measures and objectives, and there are some that are optional. So again, you do have some choice here. You do have an option here to choose whether or not you have followed the proper steps to secure your patient's PHI data in a certified EHR. And that does have some bearing on your reporting for advancing care information. All right, moving on to improvement activities. As Dr. Khanna mentioned, if you are participating in the PTN or you are a certified PCMH, you get full credit for the improvement activities category. And on the first sheet that I showed you, you can select here final score with reweighted or with full credited improvement activities. That will allow you to report. You can choose this if you are a PCMH or a member of the PTN, and you'll automatically get full credit. So you don't have to check off all of these boxes. But just to show you how it works, these are organized into categories: expanded practice access, population management. You can see here they're weighted at different levels, and then you just click the check boxes for which ones that you are participating in and which ones you're choosing to report. As Dr. Khanna mentioned in her slides, in 2017 the cost category is weighted to 0, so there's not any functionality built into the tab for cost at this time. Qualis Health will be releasing a 2018 calculator for MIPS in the coming months, and when they do so, they will be allowing you to report the cost category and all of the weights will be recalibrated to reflect the 2018 weights of all the categories. Okay, so I've entered in all my information, and this is what it has given me as results. So you see here that it's projecting for 2019 payments, and that's the first year of payment adjustments under MIPS, that the increased reimbursement would be $7,000, and you can see here that that amount goes up year over year based on the scores that I entered. It's important to note that each year CMS will be setting different thresholds for what qualifies as positive adjustments, what the scores are in the various categories. Just something to keep in mind moving forward, that these will be adjusted, and future calculators will incorporate those adjustments. It's important to know that now, though, because the numbers it gives you for 2018 and 2019 and 2020 reporting years may not be as accurate, given that those thresholds may change. I've gone back to the initial tab here to show you the results in this display. The overall score is 78 out of 100 based on what I entered. That gives maximum adjustments for the base adjustments, so 4% for the 2017 reporting year, then 5%, then 7%, then 9%. If you reach the exceptional threshold, which CMS again will be adjusting every year, if you go beyond that threshold, you can get additional adjustments, positive adjustment on top of the base adjustment. So based on what I entered, I am getting that additional adjustment. You can see here, based on what I entered, that over the 4 years that's included here, the MIPS adjustments is about $35,000 more than the base adjustments. So a pretty good outcome for a score of 78. So I've walked through this. I want to open it up now to any questions that you may have.
So questions would come in through the chat box, please.
So I'm seeing a question here, whether or not full credit is given for practices participating in the PTN. So yes, if you're participating in the PTN, you can get full credit for improvement activities. And that's also the case for practices that are participating in any PCMH program. So if you are participating in the PTN, you don't have to report other metrics on top of just reporting that you're participating in the program. I'm getting another question here that says, is it possible to use this data to submit MIPS measures? Can this tool submit directly to CMS? Unfortunately, no. This is just a tool to use for your own practice's strategic planning around which measures you may want to report and what your potential adjustment may be. The next question is the MIPS calculator free to use? Yes, this is a free, publicly available tool. I'll show again the link that you can use to find the calculator. Again, you can Google Qualis, Q-U-A-L-I-S, MIPS calculator, and I'm sure you can find it that way. Any other questions from anyone? Please feel free to enter them into the chat box.
Okay, any other questions?
Here's another question. Are any measures without a benchmark defaulted to 3 points? That's a good question. I don't know the answer to that offhand. Dr. Khanna, do you know?
So I believe all the measures have some sort of benchmark, and I would assume if you report this year, they're giving you 3 points. In the future, I think there may be more stringent guidance, but right now anyone who reports anything is getting 3 points per metric.
Yeah, you do get 3 points just for reporting in this year, and then in future years there will be thresholds that determine the points that you get. I don't think no longer will you get 3 points just by reporting anything. It'll be tied to actual thresholds.
Mm-hmm. Yeah, so as you're seeing on your screen, there are benchmarks pretty much for all of the metrics that are on the CMS website. And you would have to select from the 300 that are on the website. So technically, every one of them has a benchmark. Okay, anyone else? All right, gone. So if you would just transfer that screen back to me.
Sure. All right, Dr. Khan, I've stopped sharing.
Thank you, Russ. That was a really good presentation. I hope everyone got a sense of what value MIPS reporting would bring to your practice. And now we're going to invite Dr. Marsha Davenport, who's one of our coaches, to talk to you about how to select metrics to report. Not every metric in your that you get data for is going to be something that you like. There are going to be metrics that you do well in. There are going to be metrics you don't do well in. So Marsha is going to walk us through how to do this. So Marsha, please go ahead. Marsha, are you there? Marsha? All right, I'm going to walk you through Marsha's slides until she joins us. So Marsha and I had a chance to do this live with a practice, and we want to thank the practice for helping us understand this better. And I think in selecting MIPS quality measures, there's lots of challenges, and there are ways that you can do this better. So before you start, you want to go to this website that she has listed down here, which is the qppcms.gov/MIPS/quality measures, and look at all of the metrics that are on there. Your electronic health record will probably send you a set of metrics that they've extracted, and you may or may not have been part of that conversation. So if you have been part of that conversation, you would have already selected the metrics that you're interested in, and you will be able to see on a dashboard which ones you did well in, which ones you didn't do well in. You'll also have a chance to decide whether you want to report for 90 days in a year or you want to report for the whole year. Now, certain EHRs don't give you a choice. You know, some of these EHRs will just give you 1 year's worth of data, in which case you can't make this decision yourself. You're just going to have to report whatever measures become available to you. But if you are able to parse it out by quarter, then you can decide which 90-day period you want to report, or you can report the entire year. So in selecting measures, you want to look for measures that represent the best side of your practice, the things that you're really good at. You want to look for things like diabetes, heart disease, pulmonary. You want to look for themes that are by age categories, such as preventive services in adults and children. These are just the ways that you're going to look at metrics, and then you're going to decide, looking at your own dashboard, which ones you did well in, and those are the ones that you want to report. So identify at least 6 measures. At least 6 measures should be reported, and some of the common examples are down here, which is smoking screening and counseling in QF 28. I'm sure everybody has seen that. Influenza immunization is another good one in QF 41. This one, you need to make sure that you've learned how to document influenza vaccines that are done outside your practice. And once you become good at that, that is a really good metric to have. You also want to think about high priority measures for primary care practices, such as hemoglobin A1C, which is NQF 0059, controlling high blood pressure, which is NQF 0018. These are common metrics, and chances are that you have been paying attention to these over time, and these are usually the ones that you should pick. So also determining the appropriate outcome or high priority measures for specialty practices. So for example, you might choose in a specialty practice to use controlling high blood pressure, again, a high priority metric, or the care plan. Care plan is a really good one to use. You need to make sure that you have been documenting care plans for your high utilizer patients, or at least the ones that have come out of the hospital in the past year. And then documenting current medications in the chart, which is NQF 0419, another really good metric to choose. There are also other sources for metrics. For example, if you are participating in the Practice Transformation Network, you would have been collecting and reporting the key performance indicators to the PTN. Those are also good metrics for you to consider reporting under MIPS. And if those work for you, then it simplifies your need for going back into your EHR and finding other metrics. You should also look at your QR/UR reports, and 2016 should be available to you, where you can look at which are the measures where you've done well this past year and in the past. So if you've done well on 2016, say nephropathy maybe, then that's the measure that you want pulled out of your EHR. If it's on your list, great. If it's not, you want to ask your EHR vendor or whoever is pulling metrics for you to go in there and pull them out for you. If smoking is an area where you've done well, then go ahead and report that. And then compare what you've done in 16 to 17 and decide if you want to report these. Sometimes you may have a charge if you ask your vendors for this special request. Sometimes you won't. It all depends on your arrangements with your EHR vendors and anyone that's pulling the MIPS metrics for you. Before you make your final selection, you want to use that MIPS calculator that we just showed you to check your potential points, and then go ahead and report these. Again, reporting these metrics is possible through the New Jersey QCDR, which is their qualified registry. So anyone in the Practice Transformation Network is already working with a coach, and you are certainly free to avail of the NGII registry, which is free this year. Next year, we'll let you know whether we are able to give this facility for free or not. But for this year, certainly it is free for all of our practices, so make sure you avail of this nice resource. We put the QPP website on a slide for you, so if you need to write this down, please go ahead and do that. And now we're going to be open for questions on this. Marsha says we might have muted her. If there are any questions, please send them to us in the chat box. Okay, we're not seeing any questions. Are there any questions for Marsha? Okay. We don't have any of it. Do you check?
Can you hear me, Dr. Khanna?
Yes, we can. Absolutely.
Okay.
So our next speaker is going to be Melanie Cavalier from the MDPCP. Melanie, welcome. It is a little bit before time, 12:46, but that'll just give you more time to cover your slides. So please go ahead.
Okay, great. Thank you very much, and thank you for that great presentation on MIPS. You know, I was wondering maybe you could just give us quickly before I start a clarification of what's required to get credit for participating in the PTN for anyone on the line who may be a PTN practice.
So, sorry, Melanie, say that question again, please.
Oh, so if you can just clarify for the practices what they need to do to be sure they get credit for being in the PTN, because there are certain things they have to do. They don't just have to enroll.
Oh, yeah. I will go back to my slide and use my slide. Okay, so in improvement activities right here, so Melanie brings up a question that if you were to go to CMS and say, oh, well, I'm in a PTN, is that going to get you credit or not? So if you are a 15 and under practice, like I said, you're probably already doing this expanded practice access because you should be thinking in terms of additional times when you can make yourself available. Maybe it's a televisit, maybe it's an evening clinic or early morning availability, or you're trying to have open access for all of your patients. Whatever you're doing in expanded access, that's what makes one domain area covered. The second piece is population management. In population management, and without getting into any sort of semantics and any sort of detail, population management is simply looking at your entire practice. That's what it means. And looking at that with data, with the help of data, with trying to look at, see how many patients do I have with hypertension? How many of them are managed? How many of them are not managed well? The ones that are not managed, can I bring them back into my practice to get them on medication? So that essentially is a simplistic view of what a practice could do in pop management. You may be doing other things, like you may be tracking your patients across the continuum. You might be looking at where do they go when they go to the hospital, where do they go when they come out of the hospital. That all those things fall under pop management and crossover into care coordination. So if you designate one of your staffers to track down patients who've been discharged from the hospital, figure out where they went, whether they came back to see you, whether they went to see a specialty, and if they saw a specialist, you try and get that note from them. Again, like I said, either you get it through your EHR, you get it through the HIE, or you can do what we used to do all these years, fax it. So that is care coordination. Care coordination might also include things like, I get discharged from the hospital today, I get a call from Mary, your nurse manager, to say, did you pick up your medications? You know, those are all care coordination things that you might be already doing in a patient-centered medical home. Beneficiary engagement, this is patient-family engagement. You would be doing this in multiple ways. I'm pretty sure if you're a patient-centered medical home, if you're in the PTN, if your coach has been talking to you, you would have been figuring out, how do I get my patient more interested in his diabetes? How do I get him to take his medicines? How do I get him access so that he can reach me if he has a quick question? So maybe he can send me a message through the e-portal that I have. And you would also be inviting them to be on, say, maybe you've got a patient advisory board. Again, these are part of things that we've done in the Practice Transformation Network. So all these 4 domain areas become available to you for reporting. Some of the ones that are more difficult I didn't touch on, like emergency preparedness, patient safety, practice assessment. These are difficult for smaller practices. Achieving health equity. Health equity is not that hard, especially if you are an FQHC, and I know we have 4 of those in our Practice Transformation Network, and there's a great deal of attention that is paid to health equity in several practices, but I know that everyone can't do these. So if you are able to hit these 4 up here, 1, 2, 3, 4, and 8, any of these areas, then you've pretty much met the improvement activities that are required in a PTN. That's your question, Melanie? That answer?
That gets to some of it. I just don't want people to think just because they're enrolled they're going to get PTN credit. And I want to make them aware of what constitutes actively engaged versus enrolled.
Mm-hmm.
So, yeah. Okay, that was it.
Okay. All right.
Okay. Good afternoon, everyone. My name is Melanie Cavalier. As Dr. Khanna mentioned, I'm the Division Chief at the Maryland Healthcare Commission for the Innovative Care Delivery Division. I know many of the people on this call and have worked with them in former programs, and one of the current programs that we're hoping will be starting soon. So what I'm going to do is we're going to kind of go over this in 2 parts, as she mentioned. I'm going to go through some of the program aspects of the proposed program, and Dr. Haft is going to give everyone an overview of kind of the timeline and an update about the formal status of it. So as I go through this, a lot of you may have questions on kind of when it's going to start and that type of thing. I know we're doing it a little bit backwards, but that's because of the availability of Dr. Haft. So if you can just bear with us for a few minutes, he'd be happy to answer those questions when he gets on the call. So I'm going to talk a little bit about the ambulatory landscape in Maryland. We can go to the next slide. So there's different aspects to that. There's the PTN, which Dr. Khanna has talked about. We have about 800 providers in 90 practices. The Maryland PCP program, which is, I'm going to spend the bulk of the time going over, which is a proposed program to CMS. We do not have formal approval on that yet. Again, Dr. Haft will be addressing that, and feel free to ask any questions regarding the approval status. 2 other programs that are done through the HSCRC called the HCIP and the CCIP, the Hospital Care Improvement Program, which is for physicians that are employed by hospitals, and the Complex and Chronic Care Improvement Program, which is done through the hospitals with providers that they work with, primarily using the CCM billing code. And then this program that you're participating in today, the MACRA Awareness and Support, which includes monthly sessions that are informational as well as information that is online. We can go to the next slide. So why are we doing all this? What is all this about? What are these programs? When people talk about payment reform, what do they mean? So this slide shows physician revenue and how that's changed over time. So the majority of physician revenue is, what everyone calls fee-for-service. So basically, there's a visit, and the physician or provider gets paid for that visit. There are some pay-for-value or shared savings, a small amount of episode of care, and a smaller portion of total cost of care, which is capitated arrangements. So what the state of Maryland is really looking to move to is to increase that total cost of care. And this is really driven a lot by the desires of the insurance companies and CMS to make sure that we have a very efficient delivery system. So one of the aspects of that is cost. The other aspects that we're going to talk about are the quality of the care and the patient satisfaction. So these are the 3 things that are the main drivers and that we're tracking and talking about. So the idea is over time that less of the revenue is fee-for-service and more is paid through these pay-for-value programs, episodes of care, and total cost of care. We go to the next slide. So, again, this is the environment post-ACA. Physicians are accepting more value-based care arrangements. There's investing in more evolved care management models, establishing new partnerships. So, you know, this is really about, you know, you've heard the terminology medical neighborhood. So really working effectively with the post-acute providers, all the specialists, all the primary care, so everyone working together to try to reduce the unnecessary utilization and get the system as efficient as possible. Reducing operating costs through these efficiencies, integrating the physicians in the hospitals. So a lot of the information you'll see from the state and the new programs that are being rolled out are definitely about integrating those two entities together. And then, of course, using population health data to support the clinical improvements. Because while cost savings is great, what we really want to see is healthier people. And the belief is that the healthier the people are, the more that cost will flow into the system and create efficiencies down the road. We may not see them in 6 months, we may not see them in a year, but in 5, 10 years, our healthier population is going to help create that more cost-effective system. So the next slide, please. So the total cost of care model, we can go to the next slide. So in Maryland, from 2014 to 2018, we had what was called the all-payer model. Some people know it as the GBR, the global budgets for the hospitals. And the emphasis there was, of course, on the hospital. It was on reducing unnecessary readmissions and utilization, reducing hospital-based infections, and increasing appropriate care outside of the hospital. But since the model was mostly aimed at hospitals, you know, we want to make sure that we're incorporating, going forward, more of those entities. That's why we have the programs like CCIP, HCIP, which is the next bucket, which is the care redesign programs, which started in 2017. So they are aimed at reducing unnecessary lab tests, increasing the communication between hospitals, increasing complex care coordination for high-risk and rising-risk patients, and overall improving the efficiency of the care. So going further to the right, we see the Maryland Primary Care Program, which is intended to increase preventive care to lower the total cost of care, decrease avoidable hospital admissions, decrease unnecessary ED visits, increase care coordination, and increase community support. A lot of the aspects of the Maryland Primary Care Program are what is seen in some of these other programs, like the MMPP program that was a PCMH model, the current medical home models, and also it's highly based on the national CPC Plus model. So we can go to the next slide. So when we talk about population health transformation, what does that really mean? And as we move from left to right, we're talking about using advanced primary care practices and the care transformation organizations, as well as the state and community population health programs, or including care management personnel, practice transformation programs, a broad focus on achievable goals and performance data. And what we hope that leads to is the reduced unnecessary utilization, lower total cost of care, but most importantly, improved health outcomes and a system of coordinated care so that patient isn't being, there isn't outreach from 3 or 4 different care coordinators. They really have one doctor that's really coordinating on all their care and making sure everything's taken care of. We can go to the next slide. So the total cost of care model, that's the umbrella, okay? So before we heard all-payer model, GBR. The new model is called the total cost of care model. The MDPCP, the Maryland Primary Care Program, is one element of that model. So it is a separate contract element. It's between the state and CMMI, which is a division of CMS. CMS will issue requests for applications for practices and care transformation organizations. We'll talk more about this as I go through. CMS will be selecting the participants. when the program's approved, and then they will also require participation agreements for practices and CPOs. So can we move forward? Okay. So how is this program different from the national CPC Plus? So the national model is an independent model. Here in Maryland, it is a component of the total cost of care. Nationally, there's an enrollment limit of 5,000 practices. In Maryland, there's no stated limit, but of course all practices must meet the program qualifications. The enrollment period for the CPC Plus is a one-time application for 5 years. In the Maryland PCP, it's expected that it would be an annual application starting when the program starts and then every January thereafter. So Track 1 versus Track 2. Under CPC Plus, that's determined upon program entry. In the MDPCP, it would be all practices would be expected to migrate to Track 2 by the end of year 3. Supports to transform primary care. In the CPC Plus, it's payment redesign. In the MDPCP, it's payment redesign in the CTOs. So for the payers. So for CPC Plus, there's 61 payers nationally in the many regions throughout the United States. We just had 4 more that are starting on January 1st. So they do include a lot of Blue Cross plans, Medicaid, and other payers. Here in Maryland, we're starting with Medicare fee-for-service, which includes some of the duals, and we are working and talking with other payers and hoping that they will join us in future years of the program. Next slide. What are some of the program components? Next slide, please. So this is a driver diagram, and what this really is think of it kind of like an onion with the different layers. So if you start in the very middle with the patients and the caregivers, and as we talked about, smarter spending, healthier people, better care, the triple aim that all the programs are based around. Around that, we have these care transformation organizations, which I'll talk about in more detail, as well as the state-designated HIE. Above that, we have the comprehensive primary care functions that all the practices are expected to deliver, and I will go into more detail on these, but they're access and continuity, care management, comprehensiveness and coordination, patient and caregiver experience, and planned care and population health. So that's the top part of the circle under the complex care. So on the bottom part, in the area that's green, this is the use of enhanced accountable payments. So this is where we're talking about moving off of fee-for-service and using your revenue in different ways in your practices. The orange part, the state-designated HIE, which is CRISP, optimizing the use of HIT, and, really talk about, the quality reporting, the data exchange, and continuous improvement of that IT. So the red part is the continuous improvement driven by data. Obviously, this is a lot based on the information you get out of your health IT, but internal measurement and review and a culture of improvement. So it's really about how do we use the data that's available to us through our EHRs and the insurance companies and use that to build the more efficient systems and to figure out where we need to make our improvements in any given practice. Next slide, please. Access and continuity. So I'm not going to read every line on these slides, but I think these are good slides to show people because these tell you about what are the different care requirements that are proposed under the program. These are taken from the CPC Plus. So when this program is approved, these could look different than they look on these slides, but this gives you an idea of what they might be and what the differences are between Track 1 and Track 2. So under Track 1, achieving and maintaining 95% empanelment to care teams, ensuring patients have 24/7 access, and building the care team for a specific identifiable panel of patients. So again, these are all things you hear in the medical homes, the PTN, these other programs. So all these terms should be very familiar to people participating in those programs. So Track 2, they have to do all of those, plus regularly offer one alternative to traditional office visits, such as e-visits, home visits, group visits, alternative locations, or expanded hours. The next slide, please. So care management. So, this is really at the core of a lot of these programs, and it's definitely at the core of this program. So under Track 1, risk stratifying all in-panel patients, providing targeted, proactive relationship-based care management, providing episodic care to high and increasing percentage of in-panel patients who have ED or hospital admissions, ensuring patients with ED visits have a follow-up interaction within 1 week of discharge, and then contacting 75% of patients who were hospitalized within 2 business days. Next slide, please. For Track 2, you would need to do everything in Track 1, plus you have to do a 2-step risk stratification. So what this really means is using some type of claims-based or algorithm to figure out who falls into the different risk categories, but then also adding the care team's perception of when a patient might need to be added or even taken off or lowered based on the situation with that particular patient. So it's really using that clinical experience to determine where the true risk stratification is. And then the use of a care plan for chronic conditions to make sure that they're receiving longitudinal care. Next slide, please. So comprehensiveness and coordination, Track 1, systematically identifying the high-cost specialists. So we see this under other programs such as the PTN. I know the Care First program also has a particular focus on this, but there's going to be a lot about who are you working with and who are you referring to, and do we need to change that pattern, and how can we change that pattern if we do need to. Identify hospitals and EDs responsible for the majority of hospitalizations and ED visits. Some of these are, again, the programs that HSCRC is rolling out and is interested in rolling out are going to be ones where the hospital and the provider are working closely together. So next slide, please. So Track 2 is actually enacting collaborative care arrangements with at least specialists. These do have to be like formal arrangements. Choose and implement one option in a menu of options for behavioral health. Assessing the patient's psychosocial needs. So, often what we see is it's not the medical issues as much as sometimes it is the other issues in a person's life that are driving some of the medical costs higher than they should be. So conducting an inventory of resources and those needs as well. And characterizing the needs of subpopulations of high-risk patients and developing capability to help support those and tracking that over time. So you'll see some of this, practices are doing, but it's really bringing that that methodology to it and making it standard and seeing that it's done kind of the same all the time and really documenting that so that, so that it's being done in the same manner going forward. Okay, next slide, please. Patient and caregiver engagement, very, very important. So in this program, it's you're asked to convene a patient-family advisory council at least once annually and incorporating those recommendations as appropriate and assessing the practice's capability for patient self-management. And then in Track 2, they're required to do it in at least 2 quarters and integrating those recommendations. And then implementing self-management support for 3 or more high-risk conditions. Okay, next slide. Planned care and population health. So Track 1 is using feedback reports to assess utilization and quality performance. And then Track 2 is having regular care meetings to review the panel level data and refining the tactics. So this is a really extremely important part of the program because what you want to be doing is doing this constant quality loop where you're looking at what you're doing, making some changes, and then assessing whether that was effective, and then kind of doing that process over and over again. Okay, next slide. So quality metrics. So we do anticipate that there will be some quality measures, patient satisfaction measures, and utilization measures. So I'm not going to go into a whole lot of detail on this. So this is based on what's in CPC Plus today. So there's 2 outcome measures and 7 other of the quality measures, and then there's patient satisfaction that's based on CAPS. I know those are changing for 2018 under CPC Plus, so we're not certain, obviously, what they would be when this program would be rolled out. So next slide, please. Can we go to the next slide?
That was okay, here you go.
Okay, so the next slide that we're going to talk about is the patient incentives for better primary care. The first is track 1. So there's 3 different, can you guys still hear me?
Yes.
Okay. There's going to be 3 different tracks for the payments. One will be the care management fees. So those will be paid prospectively, and those are not subject to the quality measures per se, but they are subject to meeting the milestones for the program. So on average, they're $15 per beneficiary per month. They do go up to $50 for complex needs patients, but not very many patients are going to fall into that. So when you think about any kind of a pyramid or tier, the majority of your patients are in the bottom, with fewer and fewer going up through the tiers. And these are based on the CMS 8. We talked about the timing of it. So the second tier, which is the performance-based incentive, these are based on those quality and utilization metrics. So they're paid prospectively, but a practice may be asked to pay that money back if they do not meet those standards and measures. And then the last one, they're just paid regular fee for service under track 1. So let's go ahead and go to the track 2. Okay. So under track 2, the care management fee is higher because you're asked to do more under track 2. So it goes from $9 to $100. Again, very few people fall into the 100, and these are definitely averages. Any practice may be a little different. The performance-based incentive payment goes up to $4. They do still have to meet the quality and utilization metrics. It is subject to clawback if those aren't met. The difference here in the underlying payment structure is they have this comprehensive payment, which is a partial prepayment based on historic E&M volume, and then a 10% bonus on top of that. So, you know, the idea is that a practice will get a portion of their annual E&M revenue up front, that's bumped up 10%, and then they could use that money to do, you know, these e-visits, these home visits and things like that. So it pays for some of the time and effort that the practices are going to have to put into making this new payment model work, and the extra requirements that are required for practices under track 2. Okay, so can we go to the next slide? Application and track progression. We do anticipate that there will be an annual application process that practices may enter in track 1 or 2. So they would apply for a track. CMS may decide to accept them into track 1, or, you know, someone may apply to track 2 and they may be asked to enter in track 1. But all track 1 practices have 3 years to reach track 2, and then they either progress or they're asked to leave the program. Okay, so next slide. So let's talk a little bit about the care transformation organizations and what this means. So they are designed to support the practices to meet those care delivery requirements I was talking about earlier. So the services they can provide to practices are care coordination, support for care transitions, data analytics, standardized screenings, and practice transformation. And those are performed by care managers, pharmacists, LCWs, and community health workers. We currently don't have organizations that are called this inside of the state. However, we do have a couple different models that we think are similar to what we envision a CTO could be. So some of the models that offer similar types of supports would be like an ACO, some of the health systems. So where another entity is providing these services to support the practice, but at the end of the day, the practice is responsible for delivering those care delivery requirements, and the practice is responsible for transforming. So the idea is not that this other organization does all these, but the practice gets credit. The practice still has to actually be transforming the way they're delivering care, and that shows through these milestones that they're responsible for. Okay, so the next slide, please. Okay, next steps, let's go ahead. So I would encourage you, if you're interested in this program, to review the CPC Plus request for application. And I'm going to start on the right side because here's how we imagine this could work. So the CTOs would apply before the practices. They would have an electronic application. There would be information on ownership, legal structure, capabilities, and some required letters of support and commitment. So they would apply. They would then be selected by CMS, and then the practices would be asked to apply. So the reason CTOs are asked to apply first is because a practice may want to select a CTO. There's no requirement for a practice to use a CTO, but they may use one if they would like to. If they do decide to use one, there will be a cost share with that CTO. So practices apply after the CTOs. Again, it's an electronic application. There's detail on the ownership, demographics, their capabilities and connectivity, and required letters of support and commitment. Again, you can see some samples online for the CPC Plus. And we can share with people some potential questions that were submitted for consideration by CMS, but we don't know if that's what would actually be included in the application in Maryland. So move forward to the next slide, please. Practice eligibility. So everyone in the program has to meet minimum integrity standards. They also need to provide services to a minimum of 150 Medicare fee-for-service beneficiaries, and there's letters of support required from clinical leadership, the ownership of the practice, and CRISP. And we'll talk a little bit more about the CRISP connection in a minute. Next slide, please. So the practices are also asked to do some minimum things. You don't necessarily have to do every single item of every single care requirement prior to coming in the program, but there are certain things that we would expect most practices: assigning patients to practice panels, providing 24/7 access, supporting those quality improvement activities. These are just some minimum things that we would anticipate. For Track 2, you need to be able to demonstrate the ability to perform two-step risk stratification and also accept that hybrid payment. Some entities are not enabled to take on risk and couldn't accept that payment, so they wouldn't really be eligible for Track 2. Also be able to complete the care delivery practice reports. There's annual budgeting reporting that would be required. So one of the struggles with CPC Plus nationally was you had to say ahead of time how you were going to spend this money, because the money has to go for specific care delivery requirements. So a lot of thought kind of has to go in that. We don't know the details of what that looks like, but we do know that the majority of the funds, CMS would like to see that that's intended to go towards like care management staffing and the time for the care managers to work with the patients. And then, of course, other program requirements that would be laid out in a participation agreement. Okay, the next slide, please. So health IT. So practices are required to use a certified EHR. CRISP connectivity is required in year 1. We would like for people to get to where they're sharing clinical data with CRISP. You do need to use the latest ECQM specifications for any measures that are selected for the program, and connecting to CRISP's caliper system to report those measures. Because the state would be submitting one quality measure report for everyone that's in the program. So people would be asked to go onto CRISP to enter their information, give their information to CRISP, and then CRISP will collate that and we would send it to CMS. Okay, next slide, please. So restrictions. You can't charge any concierge fees to Medicare beneficiaries. You can't be a participant in an ACO, a next-gen ACO, or in a comprehensive ESRD model, or be part of a rural health clinic or a federally qualified health center. The reason for some of those are because they're already under an alternate payment arrangement, and CMS kind of considers that like double dipping. So that's why some of these people aren't eligible for this model. Okay, so the next slide. Support you can expect. There will be information technology support for CRISP. There will be, we would anticipate learning system vendors that will help to educate practices on how to transform. And the state is hoping to provide some additional support through the practice transformation and learning system that is on top of what is offered at the federal level. Okay, next slide, please. So considerations for participation, and Dr. Haft is going to go into this a little bit more, but what I would encourage people to do is assess the financial opportunity available, assess your practice capabilities, assess your organizational priorities, and you can see here there's 2 links to the CPC Plus and the FACS. Attend meetings on the MDPCP. We do anticipate having these on a regular basis. So every month when we do this MACRA education, we'll be doing an update on the MDPCP, but we'll also be offering other meetings. So if you go, there's a website in the next couple slides, and you'll see updates will be put out there, but we also have a distribution list for people so that they can see when the meetings are coming up. So again, review the RFA, assess the CTO options, attend the meetings, and hopefully in the summer the application. So the next slide, please. Okay, so this is the email address where the information, and I don't know if Chad's online. I think we may have updated this. So if it is, I'll make sure everyone gets that. People are also welcome to contact Chad Perman or myself with any questions that they have on this program. So if you go, we'll go through the next slide and then I'll go through some questions. So the next couple slides are just resources. These are useful videos on CPC Plus, so you can see how these work. And then the quality metrics for CPC Plus are also available. So these are just resources for people. So I'm going to take some time now to go through some questions and then turn it over to Dr. Haft to address other higher level issues. Okay, so first question, will practices participating in an ACO have to submit additional quality measures, or can the ACO quality measure performance be used? So what we anticipate is that practices in ACOs that are shared savings eligible would not be eligible for the PBIP payment, which is the one based on the quality measures. So they would get the care management fee, and if they're track 2, they would get the comprehensive payment. They would not get the PBIP, but they would still be eligible for shared savings under the ACO, and the quality measures they would answer would be, or the quality measures they would submit would be ACO quality measures and not MD measures. They would still have to submit reports on milestone achievement, which is separate from quality measures themselves. So hopefully that answers that question. The next question, will benchmarks for quality measures be given prior to this rollout? The concept is that we know how to achieve. So I don't know the answer to that. That's something that when it's approved, we'll get more information. So sorry, but at this time I don't know the answer about whether the benchmarks will be available prior to the rollout. So the next question, what is the reduced rate will be paid to track 2, and what is the % reduction of the fees? So if you go online to the link that we gave you for CPC Plus, you can see there's actually different choices, and there's different choices for each year of the program. But the idea is that it would actually increase your E&M fees by about 10% if you do the track 2 payment. That's the goal of it. But one of those videos actually, can you advance one slide to slide 37? So on slide 37, it actually has a link to a video that explains how the comprehensive payment works.
Do you want me to start any of them?
We might in a minute. Let's finish these and let Dr. Haft, but we might go ahead and do a couple of them. They're very good videos. So I would encourage people. They're very easy to follow.
So Dr. Haft is on the line now.
Okay, I just have a couple more questions. Okay. So I said practices could not be in an ACO. So there are certain types of ACOs that they cannot be in, but track 1, MSSP absolutely can be in. So next-gen ACOs and a couple of the other ones, but for the most part, the MSSPs at this time are eligible to participate. Are these slides available to download? Dr. Connor, are we going to make the whole slide deck available? I know I can make mine available to people.
Yes, we can certainly mail these out to people who are on the call.
Okay. So then there's this questions for Dr. Haft. If the model date has been delayed, can it start before TCOC? So I'm going to let Dr. Haft address that question. So Lauren or Dr. Khanna, did you see any more questions on your side related to my?
There is, Lauren, you want to read out the question? There's one more.
There's a couple. So one was, when will we know about the RFA?
Okay. I'll let Dr. Haft address that one.
Okay.
If the TCOC model start date has been delayed until 2020 and MDPCP is linked, can it start before TCOC begins?
So yeah, that's what Dr. Haft is going to talk about. So I'll let him address that question as well.
Okay.
Okay.
Were those like original ones you guys had?
Those are the ones that, yeah, I think you've looked at all of them. So I think we'll go ahead and thank you, Melanie, very much for a very informative talk. And we really appreciate you going into all the details of the program for us. And at this time, I'd like to welcome Dr. Howard Haft, Deputy Secretary from the Maryland Department of Health, to share with us some thoughts on the Maryland primary care model as it stands. So welcome, Dr. Haft.
Maryland Primary Care Program. As you know, the Maryland Primary Care Program is part of the overall contract for the total cost of care for Maryland going forward. The state and the Center for Medicare Services has agreed recently to extend the current model phase that we're in by 1 year. This is phase 1 of the model by 1 year. So that model, which was due to move to completion in 2019 and begin the second phase, will now be, as was noted previously, will be delayed. So I'd like to comment on the effect that that has on the Maryland primary care program. The primary care program, which is part of that overall model, can begin as early as January 1st of 2019, pending clearance by the HHS, the Health and Human Services, and CMS. We anticipate that clearance will occur within the next several months. Both the state and CMS are very enthusiastic about this program. Once clearance has occurred, we will release shortly thereafter the request for application, as was previously planned, and open the field to applications both from initially CTOs. This delay from our planned start date of July of this year to the planned start January of 19. However, it does for us the opportunity to refine some of the elements of the program, which could have been started, but will be made much more refined by this additional time being given to us. Particularly those issues around care transformation organizations. As you know, care transformation organizations are absolutely new organizations that don't exist any place in the country now. So we are in essence making these as startups. So there are a number of questions that still need, if not answered, refinement of the answers regarding the care transformation organization, so that they can be more effective and that the program can be more effective without any unintended consequences at startup. So we're taking this opportunity over the next several months to continue to work with our stakeholders, to continue to work with care transformation organizations and CMS to answer questions and to refine the programs to the greatest extent possible. And again, our anticipation is, pending clearance, that we will begin the program on January 1st of 2019. Looking forward to answering any questions you might have in that regard.
So at this time, we would invite all questions to come in through the chat box, please. So there are some questions that are in the chat box. Dr. Haas, can you see those, or should we read them out to you?
No, I don't see any. I don't see any new ones. There's one that says it's been delayed until the total cost of care. This phase has been, and it's not been delayed. It's been extended till 2020. But the answer to that question is that does not mean that the primary care model will not begin in 2019.
Mm-hmm. There's a question from Monique Randolph, which is, the program begins in 2019. When are applications available?
Applications will be available as soon as the program is cleared, and we'll then put the RFAs out on a website, let everyone know in ample time prior to that how to access the website.
Okay, Jennifer Teeter has a question. It's a long question. I'll read it out. She says CTOs will need an opportunity to ramp up operations. The resources will be dependent on how many PCPs are interested in applying. Has any thought been given to having PCPs submit interest prior to CTOs applying, allowing more time to ramp up?
Thank you, Jennifer. That's a very good question. And there is no prohibition to primary care providers and potential CTOs, even before the selection, to have discussions about relationships. In fact, I think that's encouraged, with the footnote that CTOs are not guaranteed to be selected until CMMI has made those selections. But I think it would make good sense to have preliminary discussions between potential CTOs and providers, such as they are applying to the program. There's, again, no prohibition to that, and it may make good sense. As we move further into the year, we'll continue to have discussions both with our providers and CTOs in open forums. We have many of those already scheduled. We'll continue to schedule those, and those might be opportunities for discussions between the participants in those meetings also.
Okay, so there is a question on a deadline for CTO application and another continuation, which is, can you confirm that participating practices do not need to use a CTO? So if you could speak to both, Dr. Haft.
Yes, I can confirm that the engagement with the CTO is entirely voluntary based on the practice's interest in doing that, as is
participation in the program entirely voluntary for the practice. The second part of that question was the deadline for CTO application. So when the RFA is released, there will be, we anticipate, about 60 days in which the CTOs will have an opportunity to respond. That application is actually open, and it's a single application for both CTOs and practices. So practices will have an ability to work on those applications. However, they cannot be submitted until after the CTO selection has been done by CMS. Because at that time, practices will have available to them information about what CTOs are available should they want to engage a CTO. So it's a two-phase process. In the one RFA, phase one, CTO application and selection. Phase two is CTOs or selection is made available to the practices, and practice application goes in. And that would be an additional 30 days.
Dr. Haft, there's a question from C. Davis. Who determines if a practice is in track 1 or track 2?
Thank you. That's a very good question again. So practices can indicate their interest in being either track 1 or track 2. However, the selection of and the placement into one track or the other is done by CMS based on the practice's capabilities compared to other practices that are applying with an algorithm. But I would point out again that all practices will move, if they stay in the program, will move by their third year to track 2.
This is an interesting question, Dr. Haft.
They're all interesting questions, Dr. Khan.
This is a really good one. So they ask, now practice can decide whether they use a CTO or not, but can a CTO decide if they want to support a practice?
So yes, it is a very good question. The answer to that is probably not, but within reason. So a CTO that has capabilities of practicing or providing services in Western Maryland could reasonably deny a relationship with a practice that is in the lower Eastern Shore because of obvious geographic issues. But outside of that, in any other major incompatibility issue, in general, CTOs will be asked to accept any practice that makes a reasonable request to use their services.
There are one or two questions that have come in about if you prefer to be in track 1, can CMS slot you in track 2 against your preference?
I think the answer to that is not likely. I would say no or not likely. If the practice is not feeling comfortable with being in the advanced primary care, they would not likely be forced to do so.
Mm-hmm. There's a question from Renee McDermott asking whether care managers need to be embedded in the practice and not employed by the CTO.
It's another excellent question. So care managers will be attributed to the providers in the practices. So they will be working under the general supervision of those providers to provide care management services incident to that provider. So they are tightly connected. They don't need to geographically spend all of their time in the practice. They can spend where it's necessary time in a patient's home, in the community, in the hospital setting, in transitions of care, but they are directly related to the provider or providers to whom they are affiliated. So whether they are coming from a CTO or coming from the practice employment themselves, their relationship is a general supervision by the providers.
Dr. Marsha Davenport asks if there is a role for specialty practices in this model.
So that's a very good question. Multi-specialty practices that have primary care providers certainly can participate, but only the primary care providers at this time will be attributed to the program. So with the exception of a psychiatrist who is working within a primary care practice, they would have an exception so that they would be able to also have attributed patients.
Okay. At this, Chris Barker has a question, and he asks, our understanding is that funds will flow through the CTOs. Is there a minimum percentage that the CTOs are required to withhold? I don't believe that.
So, yeah, let me clarify that. The funds will, care management funds specifically, will go to the practices entirely if a practice does not choose to use a CTO. If a practice uses a CTO, then they will choose to share up to 50% of those dollars with the CTO. If there's a share, a 50% share, for instance, that those dollars would go directly from the payment contractor at CMS to the CTO and directly from the payment contractor to the practice. So there's no movement of dollars between the practice and the CTO. Both would be paid independently.
Okay, so at this time, we have one more question, which is, what is the advantage of a CTO with the practice? So I think I'll rephrase this for Monique. Monique is asking, from a practice perspective, what is the advantage of a CTO?
Yes, so that's an excellent question. And in the formation of this program and discussions with our stakeholders and with experiences that we gained from learning from what worked and what didn't work in CPC Plus,
it was evident that particularly some small and medium-sized practices had difficulty in accessing some of the resources that were necessary for advanced primary care, particularly resources as in care managers or in behavioral health specialists or pharmacists, but not limited to those. And this was a way to, the advantage of practice to using a CTO is it's a way to leverage what a CTO might be able to bring together in leveraged resources around behavioral health or pharmacy or other sorts of resources that are in scarce supply or difficult to get in a small piece of that. So it might be a practice that only needed, for instance, a care manager for a quarter of a full-time equivalent. Might have a difficulty in hiring a quarter of a person, but that could be shared with another practice that needed 3/4 of a person, for instance.
Dr. Happ, there's a question, which is, sorry, were you speaking? I'm sorry.
Oh, go right ahead.
Okay. What is the reduced rate the Medicare fee-for-service will be paid to Track 2? What percentage reduction of the fees?
So it's not, not a reduction per se. In Track 2, the Comprehensive Payment Program takes what the prior history of E&M only payments were, historically looking back a year for the practice, increases those by 10%. And then the practice has an election to take a range of that as a prepayment. So somewhere between 35 and 65% of that is a prepayment. So it's not a reduction. The only reduction would be the prepayment is given up front, and then any E&M codes, so say it's a 65% prepayment, any E&M only, not procedural codes or others, not TCM, for instance, et cetera, E&M codes would be paid at the 35% rate going for that period of time. So that there is a prepayment and then a continued payment of of daily evaluation and management services. So the goal is overall to increase by 10% the net E&M payment. So, for instance, if a total payment were $100 and the practice chose to take a 65% prepayment, it would be bumped up to $110 and they would get 65% of $110 prepayment, but as visits occurred, they would get 35% of what the fee for service is. Now I point out also the billing would be exactly the same. You're not billing for 35%, you would submit charges exactly as was done previously. It's just the payment would be proportionately reduced.
There's another question, which is how many CTOs can a practice work with? Melissa Gainey says she has an agency that's considered a CTO, but they can provide services for only their consumers, not all the patients in their practice. So I guess back to the question, how many CTOs can a practice work with?
Just, they can only work with one CTO. So there may be some CTOs will decide to sub out some of their services so they can provide comprehensive services to everyone. The idea there is that the CTO should be able to provide the full range of services to any practice that needs those services.
So some more clarification is requested by Chris Parker around the withhold that CTOs can do. He says, is 50% the maximum withhold, and is the minimum negotiable with the CTO? And they have heard that the minimum is 5%. Is this accurate?
No, it's not so much a withhold as it's a share of the care management fees. So it would be up to, not to exceed 50% of the share of the care management fees. We're pending clearance. We anticipate there will be a lower level, but that would be likely 30% of the care management fees for a practice that does not need as much of the CTO's support. But that will have to, we are further refining what exactly that entails. That is one of the refinements. We have those corridors now, but we want to make sure that they actually fit reality. So, but right now it's 50 and 30, not to exceed 50.
There's a question from C. Davis which says CTOs can have collaborative agreements, so they're sharing provision of services to practices that may be outside the region but within the same practice or TIN. I think she's confirming what you just said, Dr. Haft.
Yes.
Okay. Okay, so in previous questions that we have not addressed, there is one which is similar to the question I had presented earlier. Joe Widener asks, what is the reduced rate the Medicare fee for service will be paid to Track 2? What % reduction of fees? And there's I think you already answered that, Dr. Haft, so we will move on to the next one, which is Jennifer Teeter to everyone.
So Dr. Khanna, Dr. Weider, thank you for, as always, your excellent questions. I would refer you to, on the slides, to the hybrid payment YouTube, which goes through the details of that and explains that essentially the way that it would be done is the way it's done in CPC Plus is exactly the way it will be done in the Maryland Primary Care Program. And I think that video will give you better insight than anything I can do on the telephone to explain that.
There's a clarification request from Jennifer Teeter, who asks that there are some ACOs that are listed who cannot participate, but is an MSSP Track 1 ACO that can participate?
Yes, that's correct. Any MSP, any Medicare Shared Savings Program participate except for next-gen programs or the investment programs, or a rural health program, which we don't have any in the state yet.
The next question from Chris Parker is, do you have any resources available that document how the reduction prepayment model works for Track 2 practices?
Yeah, again, I would refer you to the video for that on the hybrid payment. And that's on your slide 37. There's a link to that.
I think we've addressed all the questions there are. If I haven't got to anybody's question, can you please raise your hand so we can find your question? I think we've been through all of the questions that we had.
And excellent questions. Dr. Khan, I want to point out that we will continue to provide information and continue to refine specific answers where we develop clarity as we get closer and closer to the clearance on answers to the questions. I know that that we do have some that we've put in the parking lot, some answers or questions we put in the parking lot for now, and we're progressively bringing those out of the parking lot and getting them on the main road, and we'll continue to do that over the next month.
We do have another question that just came in, Dr. Haft. They're asking, as part of the RSA, does the practice have to share their financial statements?
No, I don't believe they require. There's a requirement to
demonstrate
integrity statement needs to be cleared, so that is. I think that's the depth of financial reporting requirement. During the program, there is a reporting requirement for how the funds are utilized, but neither does that ask for detailed financial statements for the practice, only how those funds are utilized.
Okay, so I think that's it for questions that I have. Was there anything else that we wanted to share? Or should we open a video?
Melanie, is there anything you wanted to add?
Okay, so
think of
go ahead, Melanie.
Oh, I'm sorry. So if people do have questions afterwards, you know, the team is available. So you can either email one of us directly. You can email the website that's on the I think it's slide 35, and we're happy to address questions as people think of them. You know, we're having another event on February 7th. People are welcome to attend that as well. That will be that's at Shepherd Pratt, right, guys?
Yes. So the event on 7th of February will be an evening event. It's going to be at Shepherd Pratt. We should have a flyer to send out to everybody on this list, and we'll certainly make sure you get this information so you can come. Dr. Haft has also agreed kindly to speak at our primary care forum that same day at 9 o'clock, so that'll be another forum. So you're going to have lots of chances to get your questions answered, and we encourage you to send them in to us. There is one last question for Dr. Haft, if Dr. Haft wouldn't mind taking one more question.
No problem.
Okay, so it's from C. Davis, and it is, will there be population health supports or technical supports through the Maryland primary care model?
The answer to that is yes. We look forward to getting both data and population health support from CMS and from our partners at the state HIE and CRISP. And of course, part of the fundamentals of this program are that we're very much focused on population health measures and improving population health in the state. The CTOs will provide some support for that. Both the state and the federal learning systems will also provide support.
Okay, so we are coming up on the hour. It's 1:55 right now, and there are no pending questions. So I'd like to thank all our presenters and especially Dr. Haft, Melanie Cavalier, Dr. Russ Montgomery, Dr. Marsha Davenport, for presenting today and for making this such a comprehensive discussion. Please remember that we are available for any other questions that you might have. We will certainly send them to Dr. Haft or Melanie, wherever you would like them sent. So please feel free to keep this conversation going, and we look forward to working with all of you as this program becomes real. So thank you, Dr. Haft. That's very kind. That was very nice discussion.
My pleasure, and look forward to being at your forum next week also.
Thank you all.